This podcast is for educational purposes only and does not provide medical advice or create a doctor-patient relationship. Please do not rely solely on this discussion. Always consult your own healthcare provider and verify information independently. If you're in crisis or experiencing a mental health emergency, call 911 or go to your nearest emergency department.
So today I'm very pleased to introduce our guest, Dr. Nasar Khan. He's a highly respected psychiatrist, educator, and leader in mental health with the Division of Developmental Disabilities with the Department of Psychiatry at Queen's University. Dr. Khan brings over 3 decades of experience in psychiatry with a career dedicated not only to clinical care, but also to teaching and advancing of the field. He is currently an associate professor and director of faculty development in the Department of Psychiatry at Queen's University in Kingston, where he also plays a pivotal role in both undergraduate and postgraduate learners. His work focuses on early identification, diagnosis, management of mental health conditions, especially in the developmental disabilities population. And he's been deeply involved in building capacity amongst mental health professionals globally. He also serves internationally as the Regional Vice President with the World Association of Psychosocial Rehabilitation and has contributed significantly to areas such as developmental disabilities and dual diagnosis. Prior to his work in Canada, he served as professor and head of the Department of Mental Health, Behavioral Sciences and Psychiatry at Services Institute of Medical Sciences in Lahore, Pakistan, and he has also served as the president of the Pakistan Psychiatric Society from 2018 till 2020. His academic contributions are extensive. He has authored over 100 peer-reviewed publications, written 9 books, and has trained more than 30,000 health professionals, physicians, healthcare professionals over the course of his career. So with over 33 years of experience, his impact on psychiatry spans continents and continues to influence both clinical practice and education. It's an absolute pleasure, and I appreciate you accepting the invitation to be part of Summon Neurocare's podcast series. Today's topic on developmental disabilities. What got you interested initially in working with people with developmental disabilities?
Okay, so thank you very much, Tariq, for inviting me for this talk. I was working as professor of psychiatry in Pakistan when my wife decided to move to Canada. So we got our immigration in Canada in 2014. And when I came to this country, I left everything back there and I came here. I was just trying to search for a job. Fortunately or unfortunately, with my background related to the general adult psychiatry, I appeared in 2 of the interviews and I was selected for this position in developmental disabilities. So the first 2 years, I'm not a trained developmental disability psychiatrist. The first 2 years were very difficult for me. So they were kind of a learning
curve, right?
And I learned everything in first 2 years because I was just listening and learning, doing nothing more. Okay, seeing patients was part of my responsibility and I was doing that. The first 2 years were very difficult. It was just like getting another diploma or another qualification. I had to go through all the DD, DSM and all that stuff. And my manager...
DD is a short for developmental
disabilities. Right. And my manager used to give me the books every now and then. And I had to go through them because it was part of my challenge as well to understand this population.
Can I just jump in? I apologize. And don't lose your train of thought, because it's not uncommon, because these are those subspecialties that for which there is rarely any training. Even when psychiatrists are qualified psychiatrists, they come out, they complete their psychiatry residency.
Yes.
Nobody really has any formal, or there's no residency programs in Canada.
No.
So, sometimes it is a bit of learning on the job with that special population. Because similarly, when I came for forensic psychiatry, there was no residency training program in forensics. So, sometimes you have to just learn initially and then you develop those skills as you move along.
Absolutely. So this is what the key part is unfortunately still, there is no specific training or Royal College certificate courses on developmental disability. So it was a big challenge for me. But fortunately, after 2 years, I started working in the community. I started enjoying, because there was a sense of relief and sense of gratification when you're helping the people who unfortunately are not helped by anybody else.
Right.
So it was very pleasing effect on my soul as well. I started enjoying it. And another 6 years, I decided that no more. I don't want to stay here, and I should go back to my general adult psychiatry. And
In Canada. Right.
And then I got an offer, which was definitely much more appropriate for my, again, areas where I was specializing and doing. But then I realized that if I leave this place, this division, there was nobody there to take care of the population which are having dual diagnosis.
So you felt this moral obligation.
So yes, there was something inside me which told me that no, I should not leave, because these individuals will suffer a long time, because nobody wants to understand them.
I'm super glad that you continued.
Nobody understands them, and I continued. I don't regret my decision. Sometimes I do feel that I am a cornered psychiatrist. It's not a main flow. But it's very gratifying and very, again, you can say, satisfying thing that I feel pleasure in helping these individuals, talking to them, communicating them, trying to help them, and doing my mental health stuff, whatever is my responsibility as well.
So for someone, again, these podcasts are listened to by general public, members of the community as well. So for someone who does not know, what is an intellectual disability?
In simple words, intellectual disability, unfortunately, unless or until it is formally tested by a psychologist or somebody who can assess intellectual disability, it's not labeled. It is only labeled if you have a formal assessment. Now, the formal assessment, unfortunately, comes with time. If it is recommended by the family doc, by the teachers, or by somebody else, only then the formal assessment takes place. In layman term, I can say the intellectual disability means that your cognitive functioning is slightly lower than average person.
Right.
So if you are having a processing speed of doing some stuff, an average person takes 1 minute to learn it. This person will probably take 1.5 minutes, 2 minutes, or 3 minutes to learn the same thing.
Right.
Or maybe won't be able to learn it at all.
So the DSM, the Diagnostic Statistical Manual, version number 5, describes intellectual disability. It has mild, moderate, and severe.
Exactly.
So there's three categories. Well, these are the three main categories. So in terms of the division of developmental disabilities through Queen's University's Department of Psychiatry, do you deal with mild, or do you have a cutoff in terms of?
So we don't deal with the mild.
Okay.
Right? So because mild people are still can stay in the mainstay.
Functioning in general,
understanding, moving forward, processing various kind of learning curves in life, like graduating and all that stuff.
So they have the ability to learn. Yeah.
So we don't entertain them. But people with mild to moderate, we take them up.
Okay.
Because those are the people who are having more challenges. So the IQ levels below the 70, we usually take people with that IQ level. If somebody is having 85 or 90, probably they won't fit into our criteria of accepting the referrals.
Right. So do people with intellectual disabilities experience mental health differently to others?
No. They have all the major psychiatric disorders as in general adult population. But unfortunately, the tricky component is the communication.
So it's how they express it.
Exactly. So a normal individual, if he has pain, he will express it that I am having pain.
Right.
And the pain intensity is, say, 8 out of 10. Here, the situation is that if somebody with intellectual disability is having a pain, he may hit himself.
Right.
Or he may cry, and people won't be able to understand why he's crying,
Or
because he's not
somebody
able
else.
to express
Right.
himself
Right.
that he is having pain.
Right.
So that's the unfortunate component, that the expressions, the delivery of making sure that people understand what they are suffering from is compromised as well. So unfortunately, what the basic thing is that when people have difficulty in expressing themselves, cognitively, emotionally, or otherwise, then things do get complicated. So normal person and intellectual disability are absolutely a different kind of expression.
Mm-hmm.
So if I can ask you about how are you feeling today, you will say, I'm feeling good. If you are asking the same question from the intellectually disabled people, he may smile, laugh, may make some grimaces or something else,
Right.
and not an appropriate way of expressing them. That deviation from normalcy actually creates some challenges as well.
So for somebody with an intellectual disability,
Mhm.
do you have an age range which you would see, or are you are you limited to just adults like 18 and above?
Yes. So we have 3 psychiatrists in the division.
Right.
One deals with the children,
Okay.
one deals with the adolescents.
Children with intellectual disability.
Yes.
Right.
And the second one deals with the children, adolescents with intellectual disability and a psychiatric morbidity. So dual diagnosis means there are 2 diagnoses at a time. One is an intellectual disability, and the other one is a major psychiatric morbidity, or autism spectrum disorder, or Down syndrome, or acquired brain injuries, so,
Right.
or trauma-related brain problems and intellectual disability.
Right.
If 2 diagnoses are there, then they come to our domain. And we have a child psychiatrist who deals with the children of, she sees children up to the age of 17. Between 17 and 30, the adolescent psychiatrist sees them. I see most of them, the adult population, 18 and above.
Right.
Most of them are between 30 and 70, 80, whatever.
So what is your meaning the division's catchment area?
Oh, my catchment area extends from Cornwall to Peterborough.
Cornwall to Peterborough.
Peterborough.
Like
All intellectual disabled
you drive,
people with.
you go there in person,
Well,
or do you have
yes,
some
I go, I travel,
telehealth? Do you do some OTN telehealth related?
all of it. So
Right.
in the difficult weather, when I am not able to travel, I do virtual clinics. When the weather is good, like today, I drive to those places and see people there in various clinics in Belleville, Brockville,
Right.
Napanee, Picton, Smith Falls, and all that, those areas.
Right. So for primary care, so because again, starting from primary care, a family doctor sees an individual, suspects that there may be some intellectual disability and perhaps maybe comorbid or including maybe some
Psychiatric
autism.
morbidity, yes.
They usually would refer them to me as a community psychiatrist. I would see them, my level of suspicion would be, yes, I really think that there is something here that requires a formal assessment.
Yep.
How does a community psychiatrist or even primary care, if they need to have an assessment done for autism and an intellectual disability, how do we get that done?
This is unfortunately a complicated process,
Right.
unfortunately. The easiest way would be, yes, to send them to a psychologist or a therapist who are experts in psychometric assessments, and they do the assessments like autism spectrum disorder.
Within your division?
Within my division as well, but mostly in other sectors as well.
Privately?
Yes.
Right.
And there are other in the public sector as well. DSO actually has some services available.
Developmental Services Ontario?
Yes.
Okay.
So they have some services. They accept only the people who are actually having a formal assessment.
So that's the limiting part.
That's the limiting part. That's the complicated part.
So getting that formal assessment, I mean, obviously community clinics are OHIP covered.
Yes.
But then it's getting that formal assessment done.
Is a tricky component.
Right.
Yes. But once they get into some services where the assessments can be done. So there are multiple organizations in Ontario who actually provide these services of assessing intellectual disability, autism spectrum disorder. If they give a formal assessment, then the patient is in the main flow and then it is part of the system. Then they come to us as well. They get a psychologist, occupational therapist,
Right.
social worker, prime support workers. We call them again community living, various places like Kingston. So all of those services then get into play
Right.
and try to help.
But
the
once
individual.
that diagnosis, so Developmental Services Ontario, are there other organizations that can provide these assessments?
So the assessments can be provided by multiple other organizations, like every organization which is serving these individuals, they have their own setups as well. Like in Belleville, Ontario Shores is there. There is another Pathways to Independence is there.
Right.
There are other organizations in Kingston, Onganada is there.
Onguanada,
So
yeah.
there are various places where there are psychologists, behavior therapists, and people who are doing the psychometric assessment. They are part of the process. Once the assessment is completed, then the file goes to the DSO and the patient comes into the
Right.
flow. Then we are trying to accept those individuals.
So primary care can refer to these organizations?
Yes.
Okay.
Absolutely. For assessment purposes, usually the patients should be referred to the organizations. For intervention purposes, they should be referred to dual diagnosis outreach team, which there are two of us, DDCP, dual diagnosis consultation team, and DDCOT, dual diagnosis consultation outreach team. They are two different organizations. One is with the Providence Care, the other one is with the Queens.
DDCOT is with
Providence Care.
Providence Care. Okay.
And DDCP is with the Queens.
Okay.
But the psychiatrists are the same,
Right.
of course, but the services are too different.
Right.
So if the patient is referred to DDCP, they go to different category.
Right.
If they are referred to DDCOT, they go to different setup.
Okay.
DDCOT is absolutely free. Psychology, social work, occupational therapy, psychiatry, all are free. DDCP, only psychiatry is free. The rest of the services are fee for service.
And people who just have suspicion of autism, because that is also a big kind of
Challenge.
challenge
Yes.
and concern, and patients that I see may not necessarily have a significant intellect or have an intellectual disability that would meet your criteria. Pure autism in that sense would not come under your...
No.
No.
So this was a long debate when we were doing the initial intake for the patients. We do get referrals, a lot of people who are having just the autism spectrum disorder. Unfortunately, high functioning autism doesn't come to dual diagnosis. Now, there is a debate on it. Ideally speaking, I don't mind. So there are services like with Pathways. I see people with high functioning autism as well. But with the DD card, actually their target population is not high functioning autism only. They prefer intellectual disability with autism or primary psychiatric disorder, and then we take them. So different services where we serve have different intake criteria, and they follow that. But it's not that only high functioning autism cannot be catered for. There are services like in DDCP, and there is another offshoot of DDCP where high functioning autism people are seen and they are helped as well.
Is there a resource for primary care physicians or nurse practitioners or community psychiatrists where we can at least understand a bit about this flow that you're describing?
Okay, this is difficult.
And if not, then maybe I don't know if this division of developmental disabilities could perhaps almost create some kind of a document that can help us navigate.
We do have a document. If you need help in that, we can do that. So if you contact us at DDCOT, Providence Care Services, we'll be able to send you that document.
Okay.
And then you will be able to learn all the links and resources available in the community where you can get the assessments done,
Right.
where you can get the behavior services, where you can get the assessment for psychiatrists or allied mental health specialties as well. Yes, but it's a huge document with
Okay.
all the links and the resources available.
So why can it be harder for people with intellectual disabilities to get the right mental health support?
Now, again, as I mentioned to you, misconceptions, lack of education and know-how about these things. So sometimes, like I have seen a patient who was actually 30 plus, never been diagnosed with intellectual disability, and the first time the assessment was done, and it turned out to be intellectually disabled with psychiatric morbidity. Sometimes because people are not bothered about it. Okay, this individual might be slow, lethargic,
So,
not
sorry,
very much
when you say
communicative,
psychiatric morbidity, you mean like with depression or
anxiety or anything like that.
psychosis, or
Yes.
something in addition to? Sorry.
Yes, no, absolutely, you are right. So, if the person is slow, he's not able to communicate properly, or he's shy, or he's anxious, he's not taken as having intellectual disability, right? People, they say, oh, he's a shy kind of a person.
Right.
But generally speaking, if a formal assessment is not done, if somebody is failing in a class repeatedly, ideally speaking, they should have a formal assessment of intellectual disability in the school,
Right.
which is a much easier process than when they grow up.
Pathway to get the necessary
Exactly.
help earlier
so in
on.
the schools, if the teacher is able to identify that this individual is lagging behind, there is something wrong with his intellect, and he needs the assessment, it's a very easy process. It's free of cost, it's quick, and the services can be managed as well. And if the diagnosis is established, it's good. Most of the time, teachers are not focusing on it. Most of the time, the flow is that people keep on moving forward. Once they are an adult, then it's very difficult.
Right.
Nobody understands them as well.
What kind of treatments or supports actually help beyond medication?
Oh, non-pharmacological interventions are the key. Unfortunately, there's a huge problem with the resources available in the market, available in Ontario. This is a long debate, which I always have with all the agencies supporting these individuals. Ideally speaking, in ideal world, people who are suffering from intellectual disability, plus autism, plus psychiatric morbidity like anxiety, depression, schizophrenia, other problems, they should be supported well. Now, what happened was that long time ago, these kind of individuals remain in the institutions for years and years.
Right.
And suddenly the government decided that these institutions are bad, and they opened up the community gates and sent the people in the community.
Right.
Now, in the community, there was no actually thing where
Some
they can
framework
be
that
accommodated.
yeah.
So various community living organizations generated, some private, some non-profit organizations, and they started supporting these individuals. Now, the model is they usually, if they are having problem and if they are lucky, they get a house where 6 or 8 individuals live, and they are supported by 1 or 2 staff who are able to manage them. It's if they are lucky. The wait time for any individual with intellectual disability and to get into these kind of places is about 4 to 8 years.
Wow.
So it's a long wait time. So you can imagine how much is the compromised services. Ideally speaking, these individuals should be managed in a support system where they are able to get help in everything, managing finances,
Right.
date activities of daily living,
Right.
clothing, cleaning, food, making their decisions, going to the markets, buying things, stuff,
Right.
every area.
Right.
Because all of these activities of daily living and other areas can complicate the situation.
Right.
If I get the money, $100, what do I have to do with it? So most of the individuals won't be able to understand what do they need for it. They go and buy a doll rather than buying food for themselves. And then they suffer and suffer and suffer and suffer. So the non-pharmacological interventions like activities of daily living, cleaning, hygiene, and other stuff, managing finances,
social skills,
social skills,
yeah,
interacting with the
Right.
people, developing a relationship.
So it sounds like there needs to be more investment. Obviously, there'll be individuals who are perhaps on the severe end of the spectrum
Yes.
who do need housing, who do need to be housed in, say, 24-hour supervised housing.
Yes.
That I understand.
Yes.
But I'm assuming, correct me if I'm wrong, that the vast majority are within the moderate, mild to moderate, moderate to severe range that can be managed at home. So perhaps the investment could be in terms of whether it's social work, PSW, somebody who can provide that support of people within their own homes.
Now, these services, this is a lack, and thus this is a big hole, unfortunately, here. Unfortunately, the individuals like the mild, even mild categories, mild to moderate categories, who are living in their own homes and the parents are supporting them, they have difficulties as well. Because these individuals need to learn. Who's teaching them? Either the parents or they're learning by themselves.
Right.
When they start learning by themselves, there are lots of behavioral issues because that the learning is not appropriate. Right? Brushing the teeth. If he don't want to brush the teeth and goes and just puts it and then throws it away, then of course he will start having the problems with the dental problems as well.
Right.
So these individuals needs, yes, supports, and the supports which are provided to them according to their category, as you mentioned, mild to moderate, moderate to severe, and severe to profound, is variable. That is actually done, the categorization is done by the DSO. Right? And the DSO then assesses the need-based assessment and then support system as well. So the mild to moderate people requires less support, but then the problem is the support available. So even the individuals with mild to moderate thing, if they need the support, they get into the streamline, it takes them time. How much time? You will be surprised. They become adults and they don't get those services sometimes. So there is a lack of funding, lack of resources, lack of human resources as well, which can provide help to these individuals.
If there was one message you would want to say to people as a takeaway from today's conversation, what would that be?
My only message is be aware of all these things. If you see that this individual is lagging behind in any of the domains, not only the academics, other domains as well, emotional reactivity, communication, be vigilant about it, get help from the teachers and other resources available, and get a formal assessment. If the formal assessment is completed earlier, the management in later life is much better. But if the assessment comes late, things are very complicated.
Dr. Nasar Khan, again, thank you very much for your time and really appreciate
You're more than welcome.
Your advice today.
If you want other strategies to manage, non-pharmacological interventions, so each domain will have its own big parameter. We can talk about it some other time.
Maybe we'll do that in another podcast.
Absolutely.
Thank you so much.
Thank you, Tariq. Thank you.
Appreciate it.